Hello and welcome to Fits on the Go. I'm Melissa Lyle, Cardiology Fellow at Mayo Clinic in Rochester, Minnesota, and I'm here at ACC 2019, and I'm joined by Dr. Gina Lundberg, Associate Professor of Medicine at Emory University and also Director of the Emory Women's Heart Center. Thank you so much for being here with us today.
I'm excited to be here with you.
Well, awesome. Well, I wanted to talk a little bit about women's health, and you've recently written about heart failure in women. Can you give us a little bit of an overview on assessing risk in women and managing heart failure in women?
Well, what we did was we got together some great authors who are experts on women and heart disease, Minna Walsh, Clyde Yancey, Lakshmi Mehta, many others, and we put together a whole journal of the specifics of heart failure in women. And just like with everything else we're learning about women, it's not the same. The risks are different. Unfortunately, women don't get as much treatment. The outcomes can be worse. And it's not just postpartum or peripartum cardiomyopathy. So what we're really trying to do was focus on the sex-specific treatment for women and the risk factors. And they are a little different in women. And some of these things are also preventable. Like clearly treating hypertension is important. More women, particularly elderly women, have hypertension, but less than a third of them are treated to any kind of goal. So those are some opportunities. Also, just other risk factors like alcohol, we worry about that, uncontrolled diabetes, heart failure associated with atrial fibrillation. Of course, women have more atrial fibrillation, have more burden of atrial fibrillation. So these are things we were focusing on.
All right, great. And then also, what advice do you have for fellows or people in their early career that are wanting to help develop a Women's Heart Center at their institution? What advice do you have for those people?
Well, I would strongly recommend you start one. I've started my first women's heart program in 1998, and I have really enjoyed the whole journey. In the early days, we focused a lot on awareness because, as you know, even now, only 45% of women recognize that cardiovascular disease is the number one killer of women. But as things evolved, we started focusing on research and how to diagnose heart disease best in women. Do you need a nuclear stress test or a left heart cath? Are women getting left heart caths? And of course, the answer is not like men. And then we've also moved to treatments. Do women do as well, or are there more lifestyle things? Some women's heart centers focus on research. Some are community-based. Some are academic. I think that's one of the wonderful things about it is the program can be what you want it to be. You do need leadership buy-in, and like with any other niche program, we recommend you have a business plan and a model of your mission statement and what you want to accomplish, what your goals and aims are, and really a plan of how you're going to do that. Who all are you going to bring in? Is there going to be cardio-obstetrics, cardio-oncology, heart failure in women, prevention, and just really kind of organize it. And then you start selling it to your administrators and your leadership, and you need passion, right? and then a lot of hard work and sweat. But I'm very proud of what we've developed at the Emory Women's Heart Center. There are many programs that we hope to be as good as someday. We are certainly not the only one of the best, but it's just one more group improving cardiovascular disease outcomes for women.
Great. Well, thank you so much for being here with us today. Any last sort of bits of advice or tips and tricks for overall assessing cardiovascular risk in women? What we should be thinking about as fellows?
I think the thing that's probably most underappreciated is that pregnancy really is that first cardiometabolic stress test. And a lot of times when you're interviewing a 65-year-old woman in clinic, it seems silly to ask her, well, how did your pregnancies go? Did you have high blood pressure or diabetes with your pregnancies? But we need to dig into that history. And then I think pointing out the rheumatologic disorders, lupus, rheumatoid arthritis, psoriatic arthritis, maybe even HIV, Crohn's. I think these inflammatory illnesses are higher risk in women than they are in men for cardiovascular disease. We need to point those out. And then just some of the lifestyle things, like 25% of all women report they do no physical activity. And so these are things we need to really focus into. And then I think stress and depression in women is really underappreciated. It affects their lifestyle. It affects compliance of medications. But it's also a significant risk factor. Domestic violence, trauma, just the stress of being a caregiver, whether it's your elderly parents or your children. It's a lot more that women have in that gender role than men.
Well, thank you so much for all of the advice, and thank you for being here with us today. And for more videos like this, please go to youtube.com/fitsonthego.